All right, I'll start off just by introducing myself. I'm Josh Lee, Director of Vascular Services at Premier Surgical Associates in Knoxville, Tennessee. I sort of feel like I'm coming home when I come here. I was born and raised in Rome, Georgia, went to school at Cuozzo Valley Technical College, got my ultrasound degree, and then started working here in Chattanooga. So I was here for almost 12 years before I moved to Knoxville. So coming back is kind of like coming back home. So I greatly appreciate the ability to come back and speak to you all, and thank Vic and Dr. Lassar for the warm welcome and asking me to come back. So my fun fact is in this area, wrestling is probably not the biggest sport, but I do have a junior who is a daughter, and she wrestles, and she medaled at state last year. So there's my fun fact. All right, so carotid artery disease and stroke prevention case study. Presentation and ultrasound review. So that was the topic I was given, and so we'll kind of do a little bit of that, and then some other things as well. I do have a disclosure. I get to work with the fine folks at Canon and speak for them on occasion, so that's my only disclosure. Also, nothing in this talk should have any issues with that. Also, I'm the current president of the Society for Vascular Ultrasound. If you are a sonographer and not a member, I would love for you to become a member. We're trying to improve vascular ultrasound from the societal standpoint, and would love for you to be a part of that with us. So onward we go. Okay, we have come a very long way in ultrasound from when we started until where we are today. And so I thought that it would be important for us to kind of look back at how we used to diagnose disease for carotid arteries in the past. How many of you in this building or in this room ever did any OPGs? I got one hand up. Okay, so that's dating the one person that's here, and I'm not going to say who that is, but OPGs is they would take pressures of the eyeball itself, and it would help to determine whether or not there was a carotid stenosis. So we don't do that anymore. As you could see, that's a pretty gruesome exam. I'm glad that we don't do that. I wouldn't be able to do that to any of the patients, but that's where we started. Then we had the early duplex that started in the University of Washington. So this handheld probe that had a manual Doppler that had to be moved by hand. So we are very spoiled in today's world where we can turn a knob and move our Dopplers today and have fine steering. But you can see there that particular probe took the patient's entire neck and was not able to be moved very much, and you had to use both hands to be able to get your picture. So I'm not sure who was running the actual machine and touching the buttons, but somebody was holding the probe, and maybe somebody was touching the buttons. That was before I was born, so I wasn't here to tell you what's going on with that. Then we have ultrasound arteriography. It was a thing that came out in the 70s and was used a little bit in the 90s or in the 80s as well. And this is what it would look like. They would use a wand that they would kind of rub up and down the neck, similar to what you're doing with a carotid ultrasound. But it would pick up only the fast speed of blood in the carotid artery, and it would pretty much draw an arteriogram type picture where you can see whether there was a stenosis in the carotid, the ICA, and the ECA. So we don't do that anymore. We've gotten better. So as we move on, you can see things started to get a little bit better. The machine was only the size of the wall, so the probe is a little better on this one. You still had to use two hands. You still had manual, but we're getting closer. Everything's getting closer, getting a little bit better. And here's what we have today. So this is a huge change. Our ultrasound machines are ergonomic. They move. Everything that you touch is usually a button. You don't have to do a lot of probe manipulation. And for the sonographers who started, back in the day, we love these, but we still have the ability to heel toe, move the probes around, and we can make these things sing and do all kinds of amazing things with the ultrasound machines. Even to the point where you can put an ultrasound in your pocket and carry it around with you. Pretty regularly now, residents are being given handheld Dopplers where they can go and use their iPhone, and they can pretty much with a Doppler that's about as big as this thing I'm holding in my hand, this clicker, and you can a bedside ultrasound in the hospital. So that's pretty regular these days. And so we've come a really long way to get from where we were to where we are. And this is what we look at now. We've got beautiful carotid pictures. This obviously there's no disease in this particular carotid. But this is what our gold standard is. This is what we're attempting to show. So when we're doing an ultrasound for a provider or a physician, we're trying to always make it as normal as possible. That's our goal, is to find the normal. And so if you have disease, you should never be able to make a diseased vessel look normal because it's diseased. But our job as sonographers is to do everything we can to try and make it look as normal as possible. And when we can't, then we do other things to capture additional images and give that information to our doc. With ultrasound today, you can see stents. There are times when you can see the sutures from a post-endarterectomy. The ultrasound machines are just so much better than they've been in the past, and they're continuing every day to get better and better. But AI is coming as well. There's a lot of things going on with AI. Nobody's job's going to be taken. There's always still going to have to be a sonographer. There's going to have to be someone who's going to have to run the machine. But we're going to be able to do so much more with our ultrasound machines as we move forward, even to the point where we don't even necessarily know what all we're going to be able to do. But it is helping in ultrasound and allowing us to be able to move forward and produce better pictures that our doctors can utilize to take care of our patients in a better way. So, one of the things that I want to talk about today for carotid is interpreting vascular ultrasound. And this is specific to carotid, but especially for vascular ultrasound. If you're getting an ultrasound from a radiologist, if you're getting an ultrasound from a PCP group where they may have a diagnostic center, there's most likely going to be a radiologist that's going to read that. They read their ultrasounds very different from the way that a vascular surgeon reads theirs. They're reading it based off of pictures and sometimes velocity, but a whole lot more pictures than they are the velocity. And that's an extremely important distinction that needs to be made, because a lot of times you're going to have someone's going to go to their PCP, they're going to hear a bruit, or they're going to have some vague symptoms that makes the doctor want to send them on the way to have a carotid. And the carotid comes back and it says there's a greater than 70% stenosis, and oh no, everybody's worried. And so we send them on to a vascular surgeon. The vascular surgeon does the ultrasound and says, we'll see you back in a year. Well, it's because it probably wasn't really greater than 70%, and it's the distinction of how they're read, the picture versus the velocity criteria, and that's a little bit about what we're going to talk about. But first, so just so I can understand, I know that there's a large group of different and diverse people in here. So how many of you are sonographers? Raise your hand. Okay, good, many of you. How many of you are providers? Okay, so we're definitely split. All the providers sat over here. All the sonographers are over here. All right. So how many of you create the interpretation or conclusions for your exams for your physicians? This is a question to the sonographers. Let's say preliminary, yeah. So how many of you create the preliminary? So almost the same number of people that were sonographers that held their hand up. How many of your physicians just sign the report based off the findings and don't ever look at the pictures? It's okay. There's nobody in here for Medicare. There's no law in here. They're not going to catch you. It's all right. Never happens at Vic. Never happens at Vic. Well, we'll say that for sure. However, across the United States, it is very common for that to happen. Most of our physicians are RPVI trained, and they have the ability to read ultrasounds, understand ultrasounds, and produce an interpretation. However, the sonographers are much more highly trained in that specific aspect, and so very frequently the sonographers will write the report, put down the impression, and then the physician will write their name on the bottom, and that's what you get, the interpretation. So, how many of your impressions read like this? A regular heterogeneous plaque is identified in the right internal carotid artery with elevated velocities and post-stenotic turbulence. Yay. Good, because that's not an interpretation. That is a sonographer note. That is what the sonographer found. That's what they saw. What it should say is there's evidence of greater than 50% stenosis of the right internal carotid artery by velocity criteria. A regular heterogeneous plaque of atherosclerotic etiology is identified at the proximal segment extending into the mid-segment. So that is what it should say. That's what the IEC, ACR, what our accrediting bodies require of us. If disease is present, you must characterize the severity, location, and extent, and etiology when possible, which is not always possible, but atherosclerotic disease is overwhelmingly the issue when it comes to carotid disease. Sorry, excuse me. So what we're going to talk about now is you're not dressed until you're dressed. So this is something that Leif Penrose used to say. He was a professor of mine at Cuozzo Valley Tech, which is now Georgia Northwestern Technical College, for those of you that go there now or went there. So Leif was my mentor, professor, and he would always say, you're not dressed until you're dressed. And it took me 20 years of doing ultrasound to understand what he's talking about when he says you're not dressed until you're dressed. So we're going to start out with one of my friends, and we're going to talk about how they're dressed. So this is Pat Washko. Does anybody here know Pat Washko? A couple of you. So he's also in the National Speaking Bureau, kind of like me, and we go around and speak together. So Pat dresses differently, but Pat on a regular basis would say that he's dressed in this picture. And I would have to agree, he's not nude, so he is dressed. And he would say he's dressed at his best because he's wearing his Eagles shirt, and that's because he's a big Philadelphia Eagles fan. He also paid me to say that. So he's dressed in that picture. However, in this picture, now he has on a collared shirt. So is he more dressed because he has on a collared shirt than just a regular t-shirt? But he's got shorts on now, so it's a little different. Here's award-winning Pat. Pat now has on a long collared shirt and long pants. So is he more dressed or less dressed? Now this is working Pat. This is Pat at the SVU conference, laying down getting a renal ultrasound so that someone could see his products that he provides from Canon. So is he more dressed because he's working and because he's got a really nice watch on? Who knows? This is hungry Pat. Pat's very hungry in this picture, but he's also dressed. Back to the t-shirt again. And then this is Pat from the bold days. Hopefully Pat would say he looks the most dressed here because he's got a suit and tie on and he's got hair. So that's Pat being dressed. Now, why did I go through this whole entire spiel about dressed and being dressed, when you're dressed or when you're not dressed? It's because every single lab in America is going to be a little bit different. They're going to have their very own protocol. They're going to have their very own standardized way of reading, writing, and producing an ultrasound examination, and then getting that back to the PCP and or provider that ordered it. So you're going to see a ton of different ultrasounds, all with the same patient's results there. So what are we going to do with that information? There's a ton of things that we can do to add qualifying and or clarifying remarks. These are important things for sonographers to know. This is a pretty decent, I would say, interpretation. There's evidence of greater than 70% stenosis of the right proximal internal carotid artery. There are going to be some places where you would get this report and you'd say, okay, there's a 70% stenosis. We need to do a little bit more here. We need to either send them on to a vascular surgeon or we need to, move on to the next stage because this person, especially if they're symptomatic, is going to need some sort of an intervention. However, if you look deeper into the ultrasound itself and you start looking at the velocities within the ultrasound and you're looking at the actual images and you're determining the percent stenosis at that level, what you may find is truly there's evidence by peak systolic velocity of greater than 70% stenosis within the right proximal internal carotid artery. However, the ICA-CCA ratio may suggest a lesser degree of stenosis, etiology unknown. So that's a lot of words to just say that the first group looked at just peak systolic velocity. The second group looked at peak systolic velocity and ICA-CCA ratio. We should be looking at it all as a whole. And unfortunately, that's not what happens. And so as a group of mixed folks here in this audience, you need to understand when reading, especially for providers, when reading outside studies that are coming from a diagnostic center read by a radiologist, the results of that exam could be very, very dramatically different from what you're going to get at the vascular surgery level. The folks at the diagnostic center hate when I say this, but the diagnostic center folks, they are screening for disease. They are not providing a report to the surgeon who is going to go and build a surgery. That's something that I heard very common from Dr. Lassar when I worked for him at University Surgical Associates. Build me a surgery. He wanted me to create an ultrasound and the report so that he could determine what he wanted to do in surgery. He would have it mapped out ahead of time. And so I'm sure that's probably something that he still says. If not, I'm sure it's something that he still wants. You want to have that ability to read the report, see exactly what's going on, and say, I want to take this person an arteriogram, or I want to order this person to have a TCAR. And that way you can move from one step to the next. So we're going to talk a little bit about how we get to that information. IEC diagnostic criteria. So IEC is an accrediting body for the providers that are not in sonography. And Vic is accredited with IEC. At least they were last time. Tina, are y'all still accredited with IEC? Okay, so they're accredited with the IEC. It is not a requirement for you to be accredited with the IEC. You can be accredited with the ACR, or you can be unaccredited. If they have a group of RVTs, regardless of where it is, diagnostic center or vascular lab, if you have a group of RVTs, you're not required to be accredited. However, this group of accrediting bodies have come up with how we should standardize reading our ultrasounds. And so IEC diagnostic criteria was based on It's based on peak systolic, end diastolic, and ICA-CCA ratio velocity criteria. That's how we come up with the specifics, and we're going to get a little bit more into detail. When water flows through a hose pipe, it flows freely and somewhat laminar flow, right? If you stick your finger over the end of the hose pipe, the same amount of water has to come out a smaller hole. And so the water speeds up, and you also get turbulence. So this is the easiest way to explain exactly what the ICA is asking for us to do with our peak systolic velocity criteria, our ICA-CCA ratio, and our end diastolic velocity. When we find a stenosis in the carotid artery, if there's an increase in velocity, we can identify with pretty much certainty how close this is to occlusion, how close it is to greater than 70%. We're pretty good at getting, greater than 50%. However, if it's a less than 50% stenosis, or if you plug your hose pipe by less than 50%, you may not be able to identify an increase in velocity or an increase in speed of your water, which would be the same thing as the increase in speed of blood. So that's why vascular labs and vascular sonographers read their reports as normal, 1 to 49%, 50 to 69%, and then greater than 70% up to occlusion. So that's just kind of the background of where we came from that. So moving on to the next thing, this is NASET and ESET criteria for our gold standard arteriography correlation from ultrasound to arteriogram. So I have to give a little bit of a plug here. So my son also wrestles, and he's in middle school. He's 14 years old now. He thinks he's God's gift to women in wrestling. So he said, Dad, you won't do this. You won't go into this meeting and you won't do this thing. So I'm a little bit nervous, but I'm going to make it happen anyway. I'm doing this for my son. So if we look at the NASET criteria, you've got A and you've got B, and it's A minus B divided by A. So let's just say that the diameter at A was 3 and the diameter at B was 1. So then you're going to have 3 minus 1 is 2. Easy math, right? I have to do it simple. That way, I'm kind of a simple guy. So we've got 2 divided by 3 now is how we're going to determine what this percent stenosis is. So 2 divided by 3 is 0.666667. So when you take that 0.6667 and you multiply that by 100, you get a percentage, which is 66.7%, or you can round that up to the next nearest whole number, which is 67 or 67. So there, I did that for my son. Anyway, the important thing is if that diameter was a 3 and the other was a 1, you would have a 67% stenosis. Arteriogram can get you to the exact stenosis criteria. So the difference between arteriogram and ultrasound is, of course, we're going to give a range rather than a specific criteria. So that's how we got to the point of being able to correlate with certainty that it's above 50%, above 70%, and in those ranges was how they used this NASET criteria. Now, NASET is now the standard method across the nation. It used to be kind of, you could use NASET or you could use the ESET method, but now NASET's pretty much the standard method across all. So what we did with this, and I say we, I wasn't even born yet, but what they did with this was they built a criteria based off of what they felt like was the best velocity criteria to determine stenosis. So the University of Washington criteria was based off the ESET criteria with arteriogram, and everything was based off 125. If you got 125 centimeters per second or less in the ICA, then you would know that you had less than 50% stenosis. Once you hit that 125 and went above, then you automatically moved into the 50 to 60, or the 50 to 79% category. And then when you had a 140 in diastolic or above, you went to the 80 to 99 category. So that was back in the day in the 80s. We've had multiple folks between then and now who have clarified that, who have added clarifying statements. They've added ICA-CCA ratios. They've added additional end-diastolic velocity criteria. And that has helped us to refine what it is that we're saying when we say we have a greater than 70% stenosis, and you can have certainty that that stenosis is actually a greater than 70% stenosis. I'm going to go through some of these things because some of it gets a little bit redundant. But the point is there are multiple groups of people from the 80s up to now who have said this is the best criteria. And then someone's come back and said, no, but if you add this, this will also be better. And so what has happened is we've gotten to the point in 2002, out of 100 vascular labs that were accredited across the nation, there were 11 different criteria. And so when you sent someone to an ultrasound, depending on what part of the world you were sending them to, you would get a totally different percent stenosis, even though it was the same patient using probably the same type of technology. And so the IAC said, we need to do something about this. Let's try and build a consensus. And so they and others got together and said, we're going to offer a fact that we're going to put everybody in a room. We're putting all these smart physicians and radiologists, we're going to put them in a room, we're going to lock them in there, and they got to come out with a consensus criteria. So all that did was really confuse people, because 8 years later, we went from having 11 diagnostic criteria to greater than 16, and we have to say greater than 16 because there were only 16 published criteria, but then there were multiple criteria that were independent for each lab where they had gone and built their own criteria. So now you have 16 different ways to get your ICA stenosis categorized across the nation, and depending on where you're at, you could have a 70% or less than 70% stenosis, and you might be going to surgery or not. That's where this side of the room comes into play, and that's where your provider is extremely important in sonography, especially as an ultrasound person by heart. When I would have someone who had a really high velocity, and I would send them on to my physician, and then they didn't do surgery, I was like, what the heck? Like, why are you not doing surgery? Well, it's because they're using their brain, and they're determining that, well, this person has no symptoms. This person's walking, talking. They're doing all of the things in life, and we have the ability to add different criteria, arteriograms. That's the gold standard. But then you can also do MRA and other types of diagnostic criteria to determine whether or not a patient truly needs surgery. And so I was always upset, and I was like, this person's got a 400 velocity. What's going on? Why are you not doing the surgery? Well, they're asymptomatic. They're walking, they're talking. They've got no issues whatsoever at all. And so it's not safe to do this on them at this point. Plus, arteriogram says they've got a 66% stenosis instead of greater than 70%. We're not going to do it. I was like, okay. I don't like it, but okay. So this is to get to the point. I'm running out of time, so I'm having to skip through some of these things. To get to the point, in this particular ultrasound examination, there was an 80-year-old woman that came into a hospital. While she was in the hospital, she saw the vascular lab, the neuro group, and she had two different diagnoses. One said 60 to 79%, the other one said 50 to 69%. Of course, she was asymptomatic, so nothing needed to be done. But everybody was all up in arms because in her report, in her in the EMR, she had two different distinct categories that she fell in because the vascular lab in the same hospital and the neuro lab in the same hospital didn't use the same criteria across the board. So that was an important piece for us to pick up on. So what did we do with that? We put everyone back into the room again. We said, come up with a better consensus criteria, and they did. The ICA published one, I believe it was back in 2018 where they began the publishing of that, and now they strongly encourage that vascular labs use that criteria. It's still not a requirement, so it's still across the board, everyone's using a different criteria. However, it's strongly suggested that everyone should use that criteria so we become standard across the nation. So, we have a problem. It's still not fixed, but we're working on it. So this is the criteria that they have suggested that we use, and the numbers are different. So it started out at 125, it went to 150, now the numbers are 180. So what are we seeing here? What we're seeing is things that we called worse a couple of years ago, we're now saying is probably not as bad. The percent stenosis criteria is getting more and more refined, and we're able to identify that instead of 140 as an end diastolic, 230 is a better predictor for greater than 70% stenosis. And the ICA-CCA ratio still hasn't changed very much. It's still 2 to 4. So those criteria are pretty much the same, but the end diastolic and the peak systolic have changed dramatically year after year. So then we have this whole issue of, well, even within our own vascular labs, we're getting different results because one of our sonographers uses their Doppler angle correction to the wall, and the other sonographer uses the Doppler angle correction to the flow. Well, you've got to have some sort of a standard. So in this particular picture, you got a beautiful carotid bifurcation. This one, you got a 745 centimeter per second velocity. You can't even see the Doppler correction in this one because it's an older, I won't say what type of machine, but it's an older machine, and you can't even tell where the Doppler correction is even going. So let's just take one that we can pretend for a second. So we've outlined in red where the wall is. We've outlined in yellow the plaque and the direction of flow. And so if you see there, the flow is flowing not in the same direction as the wall. What difference does that make? To you providers over here, you're probably thinking, well, what does that really even matter? Why does the Doppler have to be on the wall or to the flow? Well, every time that you change the Doppler, it's changing that coefficient that creates that peak systolic velocity. And so in that particular example, you could have a 20% or greater difference in the same lab with the same equipment just because someone chooses to go with the wall or with the flow. So the most important thing that you need to get out of that particular aspect is within the same lab, you need to have some sort of a standard, and that is either go with the wall or go with the flow. And then especially if you're repeating an exam that someone's coming back 6 months or they're coming back a year later, you want to make sure you go back and you look and you see what the last sonographer did. Did that sonographer go with the wall or did that sonographer go with the flow? And you need to try and identify, well, which one is that? There's still, at this point, there's still some controversy as to whether the wall is better or flow is better. You can almost always see the wall. You can't always see the distinct pattern of the flow. And so even though it is more accurate to go with the flow, you might not be able to see from one exam to the next exam the flow, and it's probably going to change over time as the stenosis changes different directions, right? So if you're looking at some of these pretty cartoon pictures, what you see in there is a stenosis and a blockage of a carotid artery. However, what you're seeing today is definitely not going to be the same thing that you see 6 months or a year from now. And as that carotid increases its plaque, it's going to change the flow pattern. So does that mean that you should go with the flow or go with the wall? Well, again, it's still a controversy. The most important piece that you should come out of this is that you should do the same thing within your lab so that you can be repeatable with your examinations. I just have a couple more little example. So this is a really tight stenosis here, but look at how much the stenosis has changed the flow pattern. If you're going with the wall here, you're going to go almost in the opposite direction of the flow, right? And what we know about blood and blood particles is they flow in a laminar manner when you have a normal carotid vessel. They do not flow in a laminar manner when you have a stenosis, so it changes everything. It's also helical. This is something that we identified later on in the ultrasound world, is we were thinking everything when we look at our ultrasound as 2D. You've got your black and white picture, and you've got up and down and back and forth, but really there's up and down, back and forth, and around. And so the flow doesn't just flow straight. Those particles aren't, it's not like a roller coaster ride where you're sitting in your seat and everybody's riding the same direction. Those particles are bumping into each other, and they're turning around, and they're hitting the walls, and they're flowing around like a helicopter top. So if you look at this in comparison to the other, what if this stenosis was the same thing as that last picture that we saw? So what if these two are the exact same here? If these two are the exact same, then what you're looking at here is something that's going to grow over time and change even more every time that plaque builds up and every time that plaque adds more. Or if you've got ulcerative plaque, you may have some plaque that's here today and gone tomorrow. So these are extremely important pieces that you need to pick up on along the way. Consistency is key. So I've got 2 minutes to go through the carotid review here. I did a little bit of this for you all yesterday that came for the ultrasound portion of this. This is the carotid protocol that we go through at my lab, but it's also what is suggested by the SVU and the IAC. I didn't start in the subclavian with this picture, but we usually start in the subclavian after taking bilateral arm pressures, and then we'll go in a transverse view and we'll follow the carotid up. In this particular case, there's nothing special about this case. This is just your run-of-the-mill every day, blockage. There's a little blockage in here. It's probably 50 to 69% blockage. But we take our carotid transverse picture, then we go to our bulb picture, ECA, ICA picture. As you can see, there's some hard plaque there with some calcific wall. And then we've got the right ICA distal. Everything's kind of starting to get a little bit better. We're further in the ICA and the stenosis is down. You can still see a little bit of that plaque down at the posterior wall segment. Then we go back in longitudinal and we look at everything that we just looked at in transverse. We look at it in a longitudinal view. So we're building a map for the physician so that they have from the beginning to the end and everything in the middle where they can determine what it is they want to do for this patient if this patient requires some sort of intervention. So as we're moving up, we're moving from the common carotid prox into the common carotid distal near the bifurcation, and you start to see that there's stenosis there. And as we move on a little further, you can see the split in the bifurcation. The ECA is almost not involved with this area of plaque, but the ICA is heavily involved. As we continue on, you can see the plaques only in the ICA proximal segment. We also go back and add color in. Why are we doing all these things? Why are we taking all these additional pictures? It's so you can build a roadmap for your physician. If they're going to do a TCAR versus a stent versus open-end arterectomy, they need to have the ability to make those decisions based off of the images and the report that you're giving them. So we've got wonderful flow in the common carotid, wonderful flow in the prox and mid and distal area. We move up, we start seeing turbulence. This is what we want to show the physician, is that there's turbulent flow in and around all of that plaque area, but we are attempting to normalize this as much as we possibly can at all costs. We want to normalize it as much as we can, because if we can make it normal, it probably is normal. If you can't make it normal, it's definitely not normal. And we've got our ECA picture, which has a terrible angle in it, but that's okay. And then we've got a couple more of our RCA pictures, because the sonographer that was taking this was like, wow, this is really great. I want to show this for sure. I want them to be able to see how good this is. Right ICA, 348 centimeters per second over 69.6 or 70 in diastolic. The reason I chose this particular case is because it's got a huge peak systolic velocity, but the end diastolic velocity is not that high. So in this case, as bad as it looks, this would have come from a radiology department, and they would have definitely called this greater than 70, or they would have said, go get the surgeon, make them do surgery. But in a vascular lab, we're going to say the end diastolic velocity is lower, and therefore this is less than 70% stenosis, and there's no need to have surgery as long as this patient is asymptomatic. That's also important to aspect, because if this patient was symptomatic, they're going to surgery for sure. Then we end up showing you the post-stenotic turbulence with our Doppler here at the ICA area. And we just got some beautiful pictures of how it flow normalizes in the distal ICA and begins looking more normal. Measurements are extremely important in ultrasound. You want to be able to measure the plaque, how long it is, where it is. We also measure where our probe is in relationship to the clavicle for our physicians, because TCAR is kind of a new thing and you have to have a certain amount of space there. And so giving them that specific number will allow them to determine if they want to do a TCAR versus an old style stent versus an endarterectomy. And then last thing that we do is look at the vertebral and hope that it's antegrade. And that's it. All right. Thank you very much.
Good morning. Good to see everybody. I'm Frank Cuozzo. Fun fact about me, this is my 14th full-time month with Vic, so I celebrated my 1-year anniversary with Vic, so excited about that. Another fun fact, I came from a long military career of 14 years. Another fun fact is that I did a top secret operation once, that was in the middle of a desert in Iraq in about 2016, out in the outskirts of Mosul. The Navy SEALs brought in a 400-pound man with a burlap sack on his head, shot about 15 times. And they said, "Sir, we need you to fix him." And I said, "What?" They're like, "Yeah, we need you to save his life." And I said, "Well, shouldn't you have thought of that before you shot him 15 times?" Turns out we operated on and saved his life, and then they interrogated the heck out of him. But so top secret, not top secret anymore. I'm going to talk briefly about carotid artery interventions. Let's see. So stroke is the 5th leading cause of death in the USA. It's the leading cause of serious long-term disability. It's huge cost, more than $20 billion. And the problem is carotid artery stenosis, and we've already seen that by Josh's great talk on ultrasound. We live in the stroke belt. There are incredible amount of money and time and incidences of stroke in our region. These are the symptoms, and the key, if you experience these symptoms, you get to the hospital for treatment as fast as you can. We have a very, very severe string sign carotid stenosis here as an example of when to start worrying about stroke being imminent. The imaging studies that we can do include CTA, ultrasound, and angio. There's some very good clinical trials that occurred in the past showing that surgical correction of this disease is very advantageous once it reaches certain levels. Here briefly are the symptomatic carotid surgery trials that show a basically decrease in stroke risk when you combine surgical intervention with best medical management. If you have less than 50% stenosis and you are symptomatic, there is absolutely no benefit to surgery. Asymptomatic, greater than 70% here, actually 60% in these studies did also show a benefit. So when do we perform surgery for carotid stenosis? Basically for all symptomatic patients that have a greater than 50% stenosis. Asymptomatic with high-grade stenosis, and then we use stenting in select cases of patients with high risk. This is our medical management. To control hypertension, diabetes, smoking cessation, and treat with statin, platelets, and exercise is a huge, huge benefit. Carotid endarterectomy is the mainstay. It's the gold standard of our treatment. It's been around for a long time. Patients do very, very well with minimal complications. This is basic technique for carotid artery surgery. It's an incision is made in the neck. The artery is exposed, the artery is clamped, opened, the plaque is removed, and then the artery is repaired with a prosthetic type patch. Usually the plaques come out whole, looking like this, or very calcific. Some are very friable, which increases your stroke risk. but it's very nice and satisfying to remove that. Again, the techniques, standard carotid endarterectomy techniques, basically you have to clamp the artery. And when you're clamping the carotid artery, you've got to know that the patient's brain is going to do okay. You're essentially cutting off half the blood flow to the brain. And so there are ways that we can monitor the brain. We can do it with EEGs or transcranial Dopplers. You can do the carotid surgery awake and just ask the patient how they're doing. Or you can take stump pressures. Stump pressures are taken after you clamp off the external carotid artery, the common carotid artery. You put a little needle in the bulb and you take a pressure. And if that pressure is greater than 30 to 40, it usually means that they'll do fine. This is an eversion carotid endarterectomy. It's a little bit different technique, but works very, very well. The internal carotid artery is actually taken off of the bulb, and the plaque is everted. And then you remove the plaque from the common carotid artery, and then you create a primary anastomosis back onto the common carotid artery from the internal carotid artery. Different ways, again, of doing the endarterectomy, different techniques, especially in patients who are not going to tolerate the clamp in terms of their brain perfusion. So the first way to do it would be to do what's called a shunt all the time. This way you know that no matter who gets operated on, you're still going to have blood flow through into the brain. However, there is a large percentage of patients that don't need a shunt, and there potentially could be complications with placing the shunt. The other way to do it would be a selective shunter. So place a shunt only when you need to after evaluating the patient with the various methods that we discussed. And then, so that would cover those. Here's a nice procedure. I believe this was done by Dr. Lassar, courtesy of him. This is a standardized technique for an eversion carotid endarterectomy. We marked the site right at the carotid bifurcation. He exposed the artery and then divide the internal carotid artery off the bulb. You perform plaque eversion and then sew it back on. And you got a very beautiful result there on the right. Final closure is very minimal, very small, very nice, and patients like it. So enter transfemoral carotid artery stenting. This is the CREST trial. The CREST trial compared carotid endarterectomy to transfemoral carotid artery stenting. About 18% of the cases were stenting and 82 were open carotid endarterectomy. And they really looked at perioperative stroke risk. With the transfemoral carotid artery stenting, the main concern is perioperative stroke, and they found a 2-time higher periprocedural stroke risk. So prior to 2023, in terms of carotid stenting, these were the criteria that you needed to meet in order for Medicare to reimburse for a carotid stent. And you can read them there, either surgically or medically high-risk patients, were basically all you could treat. Here's a case presentation of a carotid stent patient, 64, with a left internal carotid artery occlusion. The right was extremely tight, had significant medical comorbidities, including a long smoking history. On duplex, it was a grade 3 on the right, and the ratio was 6. So the initial step in these is taking an arch aortogram to visualize your arch and the branches. You then select the initial artery off of the arch very carefully. You shoot your angiogram defining your lesion. You advance your sheath here into the carotid. You then place a filter Okay, the filter is probably one of the most important steps in carotid stenting. You place the filter, you have to initially cross your lesion with the filter, and the filter is then placed distal, right below the cranial vault, and then that is deployed. And that is there to catch any small debris that may occur while you are stenting and or performing angioplasty. Here is where the stent is inserted into the internal carotid artery in the lesion. Here's the stent is deployed. You can see that the stent looks good. It's a little bit narrowed, or we call that wasting in the middle. We then can balloon it afterwards and get it to look a little bit better. And there's our final picture. So huge difference, and this patient did very well. It also makes for great Doppler pictures afterwards. TCAR. Transcarotid artery revascularization is the newer technique. It's probably been around for the last 10 years now, FDA approved. It combines a direct carotid access with this incredible flow reversal system during ballooning and stent placement. So this is our setup. The setup includes direct access to the common carotid artery. So you actually have to do a small cut down at the base of the neck. You then connect a sheath to a tubing system with a filter that basically is going into the femoral vein. You set up a reverse current, and then you clamp the common carotid artery. So essentially the flow now in the internal carotid artery through the lesion is going backwards. So anything that you do and manipulate the lesion during placing of the stent will actually, the embolic debris will all flow into the filter. The Roadster studies are a series of trials that have been done evaluating stroke rates in TCAR. Roadster 1 had a 1.4% perioperative stroke rate, which is very good compared to the previous trials. Roadster 3, the results from that just came out this year, and it's the lowest reported stroke rate ever. In the intention to treat group, it was 0.9%. In the per protocol group, if you followed all the rules for the trial, it was 0.6, so super low. And all the Roadster trials had very, very good results. This is Roadster 1 through 3, and you can see progressively we've gotten better. Here's the cut down technique for the TCAR. Again, a very minimal incision, controlling the common carotid artery, and you're placing the sheath. Here's the filter. This is examples of some of the debris you can find in the filter, which is pretty impressive when you're realizing that potentially we've been doing this transfemoral. So TCAR, very safe and effective procedure. The outcomes of the Roadster trials have been very amazing in terms of stroke risks. It's been FDA approved in high risk since 2015. Since 2022, we can do it now for standard risk patients. 0.9% is potentially now a standard benchmark for carotid. So in 2023, the CMS came out with a new coverage decision, and essentially basically said that we can now do transfemoral carotid stenting for the same indications that you can for open carotid endarterectomy or TCAR. Prior to 2023, CMS would only reimburse for stenting in a Medicare beneficiary that was high risk. And the result of that is that very few carotid stents were done. Under the new NCD, CMS will cover both stenting procedures under the same conditions that cover CEA. They kind of advise workup now for these patients. Carotid ultrasound should be the first diagnostic test to show whether a lesion is present. And then if revascularization is considered, some sort of advanced imaging is recommended, CTA or MRA. And then the treatment choice must be the result of standard shared decision-making with the patient. That includes discussion of all the risks and benefits for all three of the procedures. This, to me, has been the most interesting part. When you have a patient in your office and you're going through all the procedures, which are highly advanced, all the risks and the benefits of the procedures, and then you basically ask the patient, what sounds good, and most of the time they just say, whatever you recommend, doc. So I'm like, well, we shared the decision. There we go. So there is a decision-making framework that exists. The excellent part about having multiple techniques to perform carotid revascularization is that you can really tailor it to the patient, and that's what's important here. So you want to look at their surgical risk, their neck anatomy, review the imaging, looking at all their anatomy, and then also have multidisciplinary discussions with other specialties, especially cardiology, looking at their risk there. I start with the anatomy, and when you're thinking about doing a transfemoral carotid stenting, you have to start with the arch anatomy. So you have several different types of arches. You have a type 1, type 2, and type 3. And most of the time, as you age, you go from the left to right, type 1 to a type 3. The type 3 and type 2 arches actually make it more difficult to select those arteries from aortic access. The other thing is about 25% of the population has what's called a bovine arch, as you see in that below picture. The bovine arch also makes it more difficult to access the left carotid artery. And then when you're thinking about TCAR, there are pretty strict anatomical requirements to be considered for a TCAR. Your common carotid artery has to be 6 millimeters, and your distance from the top of the clavicle to the carotid bifurcation has to be greater than 5 centimeters. You need a nice runway to put that sheath in. Common carotid must be free of disease, and the depth of the carotid, essentially from the skin, it's nice when it's less than 4 centimeters. And it's also the degree of tortuosity has to be minimal. Not requirements, but help. If you have a high carotid bifurcation, that's very nice for TCAR, and not a lot of calcium either is nice. For open carotid procedures, you also need anatomical to consider where the carotid bifurcation is. If it's very high, it makes the dissection more difficult. However, we have techniques that we can use to expose a carotid artery very, very high. You can dislocate the jaw or sublux it. You can divide the posterior belly of the digastric muscle, and you can actually get very, very high exposure on the internal carotid artery with those techniques. The biggest thing, risk factor with carotid endarterectomy is nerve injury. So you have our set of nerves here, the vagus nerve. When you're dissecting out the common carotid, you have to make sure where that is. Injury to that causes significant hoarseness. Hypoglossal nerve, as you go into the internal carotid artery, you begin to see that. Injury to that will cause tongue deviation to the ipsilateral side. As you go up higher in the neck and the carotid artery, you have to watch out for the glossopharyngeal nerve. Damage to that can cause significant swallowing difficulties. And then the right recurrent laryngeal nerve becomes important when you have an injury to it on the opposite side. It controls the vocal cords, and it controls vocal cord opening with breathing. And a double injury to that could mean a tracheostomy. Again, we talked about patient factors. A couple patient factors that are important are nickel allergies and then inability to take antiplatelet therapy, which is highly recommended with any stenting procedure. There are surgeon factors as well that are involved in decision making for what you do. This is a recent article in the Journal of Vascular Surgery that came out of multiple institutions looking at the Vascular Quality Initiative. The VQI is a clinical registry, a database that submits a bunch of data points about common surgeries that are done throughout the United States and Canada. When we can use this to data mine and do research and find out very interesting things about practices and complications. So this paper compared 3 groups of surgeons. It was very interesting. There was a group of surgeons that performed carotid endarterectomies and TCAR only. That's group number 1. Group number 2 was carotid endarterectomy and transfemoral carotid artery stenting only. And then the third group did all 3. They looked at over 100,000 revascularizations, over 1,000 physicians, and over 6 years. And this was prior to the CMS decision. And what they saw is over time, since 2016, the number of carotid endarterectomies was decreasing. TCAR is increasing significantly, and transfemoral staying about the same and maybe getting a little bit lower over time. So they looked at outcomes, and the outcomes they looked at were stroke and death between the 3 groups. And what they found here in the in-hospital outcomes is that in basically group 3, the surgeons that produced carotid endarterectomy and stenting had the highest rate of stroke and death in hospital, which was significant. And also, it was true of 1-year outcomes as well. When they did a adjustment for patient comorbidities in a multivariate analysis, the second group, the patients that did all 3, there was really no difference between them and the carotid and TCAR group. But then again, we see significant stroke and death rate for the group with the just carotid endarterectomy and transfemoral carotid artery stenting. Now, when you adjusted for the actual procedure, you got no significant differences, and that's important too. So the cases performed by physicians who solely used carotid endarterectomy and transfemoral were associated with higher perioperative and 1-year stroke risks and rates than those compared with those who performed carotid endarterectomy and TCAR, and compared with those who did all 3. They did note that cranial nerve injuries were higher in the group with the transfemoral carotid artery stenting. And then when you adjust for the type of procedure form, there was no significant difference found. That means there was no confounding factors. And that's a confounding factor in a study is an observed relationship between the preference groups and stroke rates, that the stroke rates are real and not an illusion created by some unmeasured factor. The other interesting thing, I think really probably one of the most important points in this study is that if your volume of carotid stenting was high, then also your all-cause patient mortality was also high. And I think that makes a lot of sense. The procedure does have a higher learning curve, higher stroke risk, and the patients are usually much sicker. This second study was also a VQI study that looked at surgical procedures in the carotid after the decision was made in 2023. They looked at over 57,000 carotid revascularizations, and they combined them between high versus standard risk. And in the standard risk patients, there was no difference in perioperative stroke or death for the various procedures. But in high-risk patients, TCAR was found to be the safest. And in transfemoral carotid artery stenting had higher odds of stroke and death compared to TCAR. Again, probably the most important point in this study was there was a higher proportion of low-volume surgeons performing transfemoral carotid artery stenting, and we expected to see that after the decision was made. Here is a 76-year-old lady who presented in basically carotid screening with a severe carotid artery stenosis. greater than 90% on the right side here. She was asymptomatic. However, when we sent her to her cardiologist to get cleared for this surgery, the cardiologist wrote back and said, nothing, maybe a stent, nothing else she can tolerate. And so we planned for carotid artery stenting. We actually did this case last week. Here's a close-up picture of the plaque. It's severely calcific. It's a string sign, nearly occluded. We put the filter through. We managed to get it through without too much difficulty, placed a nice stent, and this was our final result. She did very well. So the take-home message about carotid revascularization, I think that all three techniques are very, very valuable in the battle against stroke. And applying the technique that gives the best chance of technical success with the least chance of risk should be the goal. You have to include the patient in your decision, and that's going to take some education, and it will take some more time that you need to spend with your patients. But an individualized approach to carotid revascularization, I believe, optimizes patient care. Thank you.